Okay, in front of these vertebrae we do have this aorta that is present, right? This is the inferior vena cava that is present. This is the wall of the like lumen for the esophagus. These things, they are basically responsible for the formation of the diaphragm that is formed by the transverse septum. Okay, this one that is going, that is moving forward, this one that is that septum transversum. Okay, these, see here, this is a muscular abdominal wall, and there are two folds. Number one, that is the right, and this one is the left, which are known as pleuroperitoneal fold, arising from the pleuro and peritoneal cavities. These are the pleuroperitoneal folds. They are also moving forward, and they are going to form some part of the diaphragm. Okay, so see here, now here they have told me how many types of diaphragmatic hernia. This is a hernia of Morgagni. So it means whenever there is defect in the septum transversum, that will lead to formation of the Morgagni hernia. Whenever there is any defect in the formation of the diaphragm that is involving your pleuroperitoneal fold, it will lead to foramen of Bostalic, like the other diaphragmatic hernia, which are more common, and they are usually bilateral. See here, they have given the location of the congenital absence. Okay, now in your exam, you may get question, what are the, where is the defect for the formation of the Morgagni hernia? Where is the defect the formation of the for Bostalic hernias, diaphragmatic hernia, which are most common? Okay, now keeping this diagram in your mind, let us see solve this question. In Morgagni hernia, where is the site of the defect? Okay, is the first one is the right option, failure of the retrosternal, like this is also a part, this is also a part that is, but this one is present behind the sternum. So the retrosternal part, the defect in the retrosternal part of the septum transversum, that would lead to Morgagni hernia. So one is the right option here. Okay, they may ask you, now see here the question number 26, like the next question, what is the cause of the diaphragmatic hernia, like your Bostalic hernias? Pleuropericardial canal defect, pleuroperitoneal foramen defect, or septum transversum defect. So we have come to know by this diagram, septum transversum defect, it will lead to Morgagni hernia. Bostalic hernia, that would be caused by the pleuroperitoneal foramen defect. So B is the correct option here, right? Okay, right. So next, see here the same thing. This is a central tendon. Here is the hiatal hernia. This is a Morgagni hernia, Bostalic hernias, which are defect in the pleuroperitoneal canals. Okay. Next one, this question that was also from the GIT. See here. What is the question? Child is presenting with hematemesis. All right. On examination, he has splenomegaly, dilated abdominal veins. Where is the problem? Okay. So what is your interpretation? What is this? Let us make this diagram. Child is coming to me with the hematemesis. All right. Number 1 point. And what is the most common cause of the hematemesis in the pediatric population? What is the most common cause? Okay. Dr. Saima, what is the most common cause of the hematemesis in the pediatric population? That is gastritis. Okay, now see here, if they give me a patient coming to me with the gastritis, but there is no clinical sign and symptoms, I would think most likely this is due to gastritis. Okay, but now see here, he has told me along with this hematemesis, the child is having splenomegaly. All right, there are dilated veins, maybe some ascites that may be present. So what is the cause here? What is the problem? This is my diagnosis of portal hypertension. Okay, so see here in the portal hypertension, definitely which vein that will be most likely affected? Definitely that is the portal vein. Okay, if I ask you which type of the portal hypertension is present in this kid, is this hepatic, is this pre-hepatic, or is this post-hepatic? So this is a pre-hepatic type of the portal hypertension. Why pre-hepatic? There is splenomegaly. There are dilated veins, though that may be ascites may be present, but he has not mentioned here. Whenever there is splenomegaly along with hematemesis, this is most likely a cause of the pre-hepatic portal hypertension. And portal hypertension means there is hypertension in the portal vein. So which vein that is involved? The option one, that is the correct. There is the portal vein that is involved. Okay, clear? Okay, next. This is the next question. Like baby that is diagnosed with the hepatoblastoma, what is the marker for that hepatoblastoma? Alpha fetoproteins. Okay, so clear. CA125, that is for the ovarian cancer. Beta HCG for many embryonal carcinomas. Carcinoembryonic antigen, which type of the, that may be for your craniopharyngiomas even. Okay, so for your hepatoblastoma, the tumor marker is alpha fetoproteins, right? Okay, moving towards the next question. Now, coming towards today's topic, that is about the task nutrition. For that, if you remember, we have done the clinical cases where they have told us about where is the absorption of different parts in the different parts of the small intestine of the different nutrients. Okay, keeping that in mind, we will solve this question. Okay, so let us see fat soluble vitamins. Very easy question. How many? What are the fat soluble vitamins? This is vitamin A, vitamin D, vitamin E, and K. So here they have given us all water soluble except this fat soluble vitamin, right? Very easy question. Question number two. They have given me different options, okay, and we have choose the correct answers from these options. Component part of the cytochrome enzymes that is involved in the myelin and the connective tissue formation and iron utilization. Okay, so what is your answer here? Dr. Fariha, what is the answer here? What is the answer here? Okay, Dr. Hira, what is your answer here for this question? Right, that is copper. First, let us see this diagram. See here how copper is involved in the iron utilization. We have done the metabolism of the iron, but in that scenario which they have given in your SOP book, copper, they were just, they told us like, yes, copper is present, that is involved, but how it is going to be effective in the iron utilization. If you remember, if you memorize, whenever we do like in our practical patients, we always give vitamin C supplementation in the iron deficient patients and always ask them to take the food that is rich in the copper. Why? This copper and this vitamin C, they are going to enhance the copper reabsorption. How? Let us talk about the copper here. This is the copper that is present in the intestine. Okay, I have eaten the copper that is going into my intestine. Then copper, it is being absorbed. After absorption, it is going to the portal circulation. Then it's moving to your liver. Okay, in the liver, this copper that is going to release to cause the formation of the ceruloplasmin. That is a copper containing protein. What is the role of this copper containing protein in the iron? See here, it is going to be work synergistically with the ferroportin, with hepcidin. Why? These are the proteins which are responsible for the reabsorption of this iron from the enterocytes. How it is going to do it? It is going to convert the ferric form of the iron into the ferrous form. Like this ferroportin that is basically responsible for the entry of this ferrous form into the enterocyte. This ceruloplasmin, it is going to work synergistically with this protein. So it is going to convert ferric form into the ferrous form, and then this ferrous form, it is going to enter into the enterocytes for the reabsorption. This is the basically role of the copper for the iron utilization. Okay. Now see here another, it has also told like iron being utilized into the cell. So basic role is, see here, transportation. transportation by the ferroprotein into the enterocytes, and from the enterocytes into the bloodstream by the transferrin. So this is a card that is carrying out your iron, and it is going to move into the enterocytes and from the circulation into the different cells of the body. Okay, this is the role of the copper for the iron utilization. Okay, if we talk about the different enzyme, if I have taken the picture, there are different enzymes where copper is the main regulatory enzyme, main regulatory part of that enzymes, which are being formed, being utilized in the iron utilization, even in the electron transportation channel in the formation of the melanin. So, myelin, melanocytes, iron utilization, connective tissue, even in your immune regulation, this copper has a major role. Whenever, please do remember, whenever you treat iron deficiency anemia, like in the patients coming to your OPDs, give them vitamin C supplementation, give them copper supplementation, like ask them to take the food that is rich in copper, that is rich in vitamin C. Okay. The next question, calcium and phosphorus absorption from the gut and calcium retention from the kidney. That is the vitamin D. Very okay, any ambiguity in this question? Vitamin D that is going to reabsorb, increase the reabsorption of the calcium and phosphorus. We have discussed that from the GIT and from the kidney. This is the role of the vitamin D, right? Next component mainly stored in the bone and involved in the muscle contraction. We also have discussed that. That is your magnesium, right? Okay. So the next question, which one is a fat soluble vitamin? See here, now here they have given vitamin A among the options. Okay. Next question. 11 years BMI, that is 31, very high, plotted plus 3 standard deviation score, which is severe obesity. Which is correct option here? Okay. BMI assessment of adiposity percentage. Okay. Is A is the correct option? Is A is the correct option here? Yes, Dr. Shah, that is going to convert ferrous to, basically it is not going to convert directly ferric. It is going to act synergistically with your ferroprotein to convert this ferric into the ferrous form. You will see vitamin C also has the same role. I will show you in the next question. The vitamin C is also going to have the same role, converting ferric into the ferrous form by an enzyme that the name of that enzyme is vitamin C reductase. So both your copper and your vitamin C, they are going to enhance the iron utilization in this way. Okay. Yes. Contraction. No. See here, magnesium that is going to enhance the contraction. Okay. Whenever we see they are basically going to increase the action potential. Okay, it is going to just work like your calcium. Whenever the fits they are not controlled, we first give the calcium level, then after giving the calcium, if it is not controlled, then we will give the magnesium. Both have the same role in the contraction of the muscles, in the increase and depolarization of the action potential. Okay. Okay. So the next question, okay, I'm talking about the question number 4. She's 11 years, BMI is 31. Which one is correct? I'm asking, BMI is the assessment for the adiposity percentage? Not at all. Overall, seems like this BMI that is going to calculate my fat, but it is not. If we calculate the formula of the BMI, that is going with your weight divided by height in meter squares, right? So is this going to measure your fat? Not at all. It is just for the assessment of your weight. See here. Does BMI measure your adipose tissue? BMI is calculated by your weight, that is divided by your height. Meter squares are squares. What it doesn't take into account is how many of those pounds are fat and how many are lean muscle tissue. It's not the best indicator of how much body fat and how much muscle has one. Okay, so please do remember, it seems like it is going to measure my fat, but it is not like that. It is just going to measure my weight according to my height, right? So this A option, that is not the correct. It is not going to assess my adiposity percentage. BMI plus 3 standard deviation approximately to 98 centile. No, not at all. That is more than 99.6 centile, right? BMI at the 50th centile change throughout the childhood. Okay, so see here, basically, if by excluding A and B option, we come to the B point, that is the best one. Why that may change? This change doesn't mean it is going to increase or this is going to decrease. Okay, who will tell me? If I am going to say like this is plotted at the plus 3 standard deviation, what does it mean? Is it going to increase or decreased? It is going to increase. Okay, so C is the best option here. Why? It means that is going to increase. Plus 3 standard deviations mean like not exactly for the age, but yes, that is going to increase throughout this time period. The point here is that we have to exclude these two are definitely not. So C is the best option among all these three they have given, right? Okay. Next question, vitamin D dependent rickets, X-linked hypophosphatemia. They have given different types, and here they have given me different scenario. 18 years old girl, faltering growth. Urea is normal, creat is normal, calcium is normal. Okay, calcium is normal, phosphate is normal. Okay, raised alkaline phosphatase. PTH that is raised, but 25 hydroxy vitamin D that is very low. 125 hydroxy vitamin D that is very low. What is your diagnosis? Is this chronic renal failure? Okay, let us exclude all other causes. Is this chronic renal failure? No. Why? They have given me urea and creatine that is normal, so this is not a case of CR. Is this a acute renal failure? In the acute renal failure, I am not, definitely not. Urea and creatinine, they are normal, and they acute are not going to do anything with calcium, phosphorus, and this all other things. Okay, is this a case of primary hyperparathyroidism? Is this a case of primary hyperparathyroidism? No, in that case there will be hypercalcemia. Number 1 point. Phosphorus, yes, phosphorus is normal, and there will be hypophosphatemia. So this is not, is this X-linked hypophosphatemic rickets? In the X-linked hypophosphatemic rickets, calcium may be normal, but normal phosphorus is going to exclude hypophosphatemic rickets. Okay, all right. Is this vitamin D dependent rickets, or is this vitamin D deficiency rickets? This is vitamin C here. In the vitamin D deficiency, initially you may have normal calcium, you may have normal phosphate as a part of the compensation. There is a secondary hyperparathyroidism that is going to raise your alkaline phosphatase level. But see clearly, they have given me like 25 hydroxy vitamin D level that is very low. Okay, it's very low, and 125 that is 80 that is in the normal range, ratio that is normal. So by excluding all other causes, definitely this is not vitamin D dependent rickets. In the vitamin D dependent rickets, your 125 that would be decreased, your 25 hydroxylase that would also be decreased. So why this is vitamin D deficiency? They have given all those things, they are normal, but secondary hyperparathyroidism, it is this due to raised alkaline phosphatase and increased PTH. Why this is increased? This is due to deficiency of vitamin D, deficiency of 25 hydroxy. Whenever there is, we have seen what is the sensor for the release of the parathyroid hormone. Is this 125 or is this 25 hydroxy? This is 25 hydroxy. When it is decreased, it acts as a sensor for the PTH, and there will be increased release of the PTH, parathyroid hormone, right? To activate your vitamin D. See here in the vitamin D dependent rickets, your 125 that would also be decreased. Okay. Okay. Moving towards the next scenario. The second scenario, urea is normal, creatinine is normal. So this is not a case of CRF. This is not a case of ARF. Okay, calcium, they say that is very much high. Phosphate, that is decreased. Increased calcium, decreased phosphorus, raised alkaline phosphatase, and raised PTH. PTH, that is also increased, and alkaline phosphatase, that is also increased. So, what is your diagnosis here? What is your diagnosis? This is very much clear. 25 hydroxy, that is our sensor for the release of the PTH. See here, I just wanted to tell you, like if you have decreased level of the 25 hydroxy, or if you have a decreased level of the 125 dihydroxy cholecalciferol, so the sensor for the release of the PTH, that is the decreased 25 hydroxy vitamin D. Okay, that is going to increase release of your parathyroid hormone. This vitamin D deficiency, 25 hydroxy vitamin D deficiency, it is going to release your PTH. Okay. Okay. So next is a question. This is very much clear. This is a case of if alone 125 decreases, then it's vitamin D dependent. No. In the vitamin D dependent, 125 must be decreased and 25 it may or may not be decreased. But in the vitamin D deficiency, usually this 25 hydroxy that is decreased. Ideally, in deficiency, this may be decreased, this may be decreased. But see here, why we have told here this is vitamin D deficiency, there is decreased release 25 hydroxy that is very much decreased, and it is going to make a sensor for the release of the PTH. So PTH is going to release, that is why there is the PTH level that is high, alkaline phosphatase. PTH is going to act on your osteoclast and it is going to increase your alkaline phosphatase level. Okay, in your dependency this would be decreased, 125 would be decreased. Okay, usually. Okay. So next question was about the hypercalcemia. That is very much clear. When calcium is increased, when phosphorus is decreased, PTH is raised, it means it is going like this. There was increased release of the PTH. Okay. It is going to increase the absorption of the calcium. It is going to release of the increased excretion of the phosphorus. So phosphorus will be increased. And due to action on the osteoclast, there will be increased level of the alkaline phosphatase. Okay. So the next question, enhance the iron absorption. T, definitely not. It is going to decrease iron. Vitamin C, yes. How it is going to increase? See here. This is again the iron physiology. Iron that I have taken, it was in the ferric form. It is going to be my enterocyte. And see here what we have read before. Like there is divalent metal transporter which is going to convert the ferrous form, like enter the ferrous form into the enterocyte. But how it is going to convert? This is your vitamin C ferrireductase. This is an enzyme that is enhancing the same thing that was by your ceruloplasmin, by your copper, which was also going to work with your ferroprotein to enter into the this small intestine. But before that, it has to convert ferric form into the ferrous form. So your vitamin C that is going to absorb the increase reabsorption by this step, and the same is the step that is being conducted by your copper. Okay, always give copper and iron to the iron deficient patients. Right. Moving towards the next question. See here again the same things about the vitamin supplementations. Okay. Obese child, he is always on TV and eating fast food. Lazy lifestyle, plan to start on orlistat, that is a drug. Okay, what should be given? Okay, why should we give the vitamin D to the patients of who is on the orlistat? Number one point, when we read the guidelines for this obesity, we have seen they are not talking about the orlistat. They say just go for if BMI that is more than 40 kg per meter square, or if it is more than 35 with any morbidity, then you should go for surgery. Okay, in the latest recommendation orlistat, they have not said. Okay, but see here, they basically here want to ask you what is the side effect of the orlistat. First of all, I will tell you what is the mechanism of action of the orlistat and how it is going to act on your vitamin D. It's not only your vitamin D, it's basically your fat soluble vitamins. Okay, keep this thing in your mind. They may give you other things, most likely that is the vitamin D, but definitely it is going to decrease the interfere with the reabsorption of the all fat soluble vitamins. Okay, let us see. This is the fat digestion and this is the oily start. That is the mechanism of action, right? I have eaten this fat. Okay, this fat that is present in the small intestine. Okay, whenever there is fat, your pancreas that is going to release your lipase. This lipase then it is going to act on your fat cells, your triglycerides, and it is going to convert into monoglycerides, and due to this degradation, these are going to absorb. So it is going, there is fat reabsorption. Okay, what is the mechanism of action or the orlistat? It is going to decrease the reabsorption of the fat and fat soluble vitamins. Okay, so when there, if I have eaten the fat but I have also taken the orlistat, right? What this orlistat is going to do? It is going to bind your lipase. When it is going to bind your lipase, there will be no degradation of the fat. Fat will be present in increased amount into your body. Okay, it will not be reabsorbed. It will not be broken down. It will not be reabsorbed in the intestine. There will be increased fat, and it will lead to your steatoria. Due to steatoria, your fat soluble vitamins A, D, E, and K that will be affected. So, whenever you give a patient orlistat, the most vitamin that is most likely affected, this is vitamin D. So, you will give vitamin D supplementation to the patient who is on orlistat. Okay. Next question. 6 months baby weaned from the exclusive breastfeeding. Mother is a vegan and plan to start him on the vegan diet. What should be given? We have read most likely it is vitamin B12, but maybe other deficiencies that may be present. Okay, right. The next question. 4 month breastfed weaned on the formula with history of the nappy rash, perioral and perianal dermatitis, scalp hair loss. What should be given? Any ambiguity, that is the acrodermatitis enteropathica, that should be given zinc supplementation. Okay, basically that was, we have done a clinical case for that where a table that was given what are the signs and symptoms of the vitamin A deficiency, your eye problems, your steatoria, and fat soluble vitamin malabsorption may be present. With the vitamin B12 deficiency, there may be macrocytic anemia and ataxia. Your spinal cord, dorsal column of the spinal cord that may be affected. With the vitamin K, your PT and APTT that will be deranged and patient may comes to you with the bleeding. With the zinc supplementation, that is ectodermatitis enteropathica, perioral and perianal rash may be present. With the vitamin E supplementation, there may be hemolytic anemias. Okay. With the vitamin E supplementation, the patient may comes to you with ataxia. Okay, like that is vitamin E deficiency, which is present in which disease? That is your A beta lipoproteinemia. Okay, vitamin D deficiency will come with the rickets. Okay, reading the next question. See here, question number 8. Best value that presents vitamin D deficiency in a girl who is 18 months old with a frontal bossing and bowing of the legs. Okay, calcium, like they have told you, this is the calcium, this is the phosphorus, then your alkaline phosphatase and PTH. Okay, what is the importance of telling this girl and 18 months? Okay, what will be present? Here, basically, they want to tell you that's an X-linked dominant condition, that is your hypophosphatemic rickets. So, the importance of telling a girl here is that this is a case of X-linked hypophosphatemic rickets. Okay, so in the X-linked hypophosphatemic rickets, like a girl is coming to you with a short stature with a bowing of the legs, your calcium may be normal, but your phosphorus will be low. There will be, due to, there will be increased level of increased release of the PTH, and definitely then when PTH is increased there will be high level of the alkaline phosphatase. Basically, see here in the option A, they are saying there is low calcium and high phosphorus. Can phosphorus be high? Okay, what is the disease where is decreased calcium and high phosphorus? What will be the decreased conditions? There will be hypoparathyroidism. Is this a case of hypoparathyroidism they want to tell you in a girl? Yeah, this is not a hypoparathyroidism. No, no. Okay. If see here, Dr. Fariha, in the CKD, PTH level will not be decreased. Okay, there is low calcium, high phosphorus, but in that case, PTH level will not be decreased. That will be secondary hyperparathyroidism will be present. Okay, so this is not definitely not a case of hypoparathyroidism. Low calcium, high phosphorus, alkaline phosphatase normal, PTH normal, that cannot be happen. If this is a case of CKD, then its level will be increased, and if it is due to hypoparathyroidism, their level will be decreased. Okay, so this is a girl who is having X-linked hypophosphatemic rickets. So in that case, phosphorus will be decreased, calcium will be normal, and PTH level will may be increased. So B is the correct option here. Okay. This is the case we have done with your clinical cases. What is the constituent of the mother feed and the cow's milk protein in your FOP examination? Why PTH is high? In which case, see here, like whenever there is an X-linked hypophosphatemic rickets, there is decreased level of the phosphorus. This calcium level, though initially that is normal, but it can also be increased in that cases. There is no like not a hard and fast rule this PTH level that will not be raised. There are different sensors, that is your increased level of the phosphorus number one and decreased level of your calcium. These two are the sensor for the release of the PTH. And number one thing, the like there is a fibroblast growth factor 23 in your hypophosphatemic rickets. This is not affected by your calcium, this is not affected by your phosphorus. This is basically affected by your fibroblast growth factor 23. Okay, which is going to be act on your PTH, and it is going to increase the level of that your parathyroid hormone. In your hypophosphatemic rickets, these sensors about your calcium and phosphorus, they are not the main regulator for the PTH release. It is the defect, it is a genetic mutation in your fibroblast growth factor 23 that is going to act for the release of your PTH. Okay, I will send you, I have collected literature for that, where this basically the main pathology is in the fibroblast growth factor. Okay. Okay. So next is a question that is about the cow's milk protein in the newborn, where I have told we have discussed that cow's milk protein is having high protein content. There was a question in your FOB examination where the child was having kwashiorkor. What is the treatment of the choice? That was by the cow's milk. Why? Cow's milk is having high protein content. Okay, so in the patient who are coming to with the kwashiorkor with a protein deficiency, their treatment of nutrition of the choice is the cow's milk, not the mother feed. Okay, the same thing they basically want to ask here. Cow's milk protein is having high protein content if whenever it is compared to the mother feed. Right. Next question again, WHO definition of the obesity in below 5 years. Okay, now see here, you will memorize what are the definition of the. This is the early state mechanism. The drug is interfering with the absorption of the certain vitamins. These are the fat soluble vitamins. Okay. This is the definition of WHO definition for the obesity, the child who is less than 5 years, for the children who are between 5 and 19 years. Okay, so what is that? Obesity, what is the definition of the obesity and what is the definition of the overweight? What they have given in your guidelines, they are not according to your WHO criteria, but they have asked, and you must know what is the WHO definition for obesity. Okay, let us see. What is that definition under 5 year? Obesity is weight for height. Okay, we measure weight by height greater than 3 standard deviation above the WHO child growth standard medians. Okay, okay. What about the 3 standard deviation that is for your children who are less than 5 year, who are between 5 and 19 year? Obesity is greater than 2 standard deviation above the WHO growth reference medians. Okay, this is the difference. Overweight that is greater than 2 standard deviation, and in the between 5 and 19 years, overweight is BMI for age greater than 1 standard deviation above the mean for median, reference median. Okay, I'm modifying. Sorry, sorry. Which question? Okay. What most important factor to modify cow's milk for the newborn? Okay, sorry, I just interpreted like this, but they are asking about that comparison. Okay, all right. Yes, Dr. Saima, that is basically the high phosphorus content. Right. Yeah, that is also high in phosphorus. That is for the newborn. And for the kwashiorkor, we have read a question in your form that this protein, that is cow's milk, that is also high in the protein content. Okay, for that, the treatment of that children is the cow's milk protein. For the patient who is coming with the kwashiorkor, in that case, we also recommend cow's milk. Why? That is very much high in the protein content. I just took it like that, but yes, you are high. They are basically asking for the high phosphorus content. Okay, okay, that is an indication for the kwashiorkor, right? Okay, next question. This was WHO definition less than 5 year and more than 5 years. So for that we will read, is that about the more than 3 standard deviation are for between 5 and 19 year, that is more than 2 standard deviation. So you have to memorize these two definition according to WHO criteria, right? Okay. So next question, this one. This is again the repetition component part of the cytochrome enzymes. This is your copper, calcium, and phosphorus absorption from the gut. Okay. This is the same question. Intracellular component mainly stored in the bone. This is your magnesium. They have given the options below here. This is the same question done before. Okay, breast milk components. Answer for the last question. Which one? This one? They have given the correct option here now. This one. See here. Obesity definition. Let us talk about this one. Obesity definition according to WHO under 5 year is that BMI more than 3 standard deviation, BMI more than 2 standard deviation. No. Obesity is the weight for height greater than. Okay. Okay. Right. So next option, this one. Question number 12. Breast milk component antimicrobial, that is by binding to the free iron. See here they have given the options number 1, number 2, number 3 and number 4. So they have told you like there was not option for the beta lactalbumin and like globulin. So what is the antimicrobial that is binding to the free iron? Which antimicrobial that is present? Is this lactoferrin or is this IgA? C is magnesium. Sorry. Yeah, you are talking about this question. Yeah, we have done this question before. See, the first question we did, that is magnesium. Yes, that is magnesium. Okay. Okay. Moving towards the next question, breast milk component. Just 1 minute, please. We will do this question number 12. Just 1 minute. So this is the question number 12, breast milk components. So antimicrobial that is binding by the free iron. What is that? Is this lactoferrin or is this IgA or oligosaccharides? Okay. No, yes, magnesium causes muscle contraction. Magnesium is just like acting with your calcium, it causes contraction of the muscles. Okay. Dr. Hira, you were asking about this. Yeah, we have done this question. See, we have discussed that when we discussed in, I guess that was the first question we discussed with the task nutrition. Okay. Right. So breast milk component, the antimicrobial that is binding to the free iron. What is that? Is that lactoferrin? Is that immunoglobulin? Or is that oligosaccharides? So the answer for that is binding to the free iron, that is the lactoferrin. Okay. That is neutralizing and binding to the antigen leading to the tolerance. What is that? That is your IgA, immunoglobulin A. Okay. Right. it produce acidic media. Definitely, which one is producing your acidic media? This is your carbohydrates. And allowing lactobacilli to flourish, that is your oligosaccharides. Right? So they have given the options 1, 2, and 3, A, B, and C. Okay, the next question, moving towards the next one. Neonate with biliary atresia. Okay, with this we have done Kasai procedure, that was done. Now mother says he has diarrhea and he's not gaining weight. She said he is on the formula feed. Which milk? Is that soya milk? Not at all. What about the extensively hydrolyzed formulas? What about your high carbs, high protein, enhanced medium chain triglycerides, high carb, high protein, long chain polyunsaturated? Which one is the correct option here? C is the correct option. Why? This is because there is steatorrhea, there is decreased fat reabsorption. So what we will do? We will give medium chain triglycerides. We read yesterday why medium chain triglycerides? They are directly absorbed to your portal circulation. They do not need to be degraded into lipases by the lipases. So what we will use? We will use the formula that will contain medium chain triglycerides. Okay. What about the extensively hydrolyzed formula? We told, we have read, we usually use them in the cow's milk protein allergies. Okay. Long chain polyunsaturated, definitely that cannot be used. So C is the correct option here, right? Okay, the next question, again the repetition. See here, okay, I will read it. Caucasian mother with balanced food, baby exclusively breastfeeding till 1 year old. What vitamin to be deficient? Mother feed is deficient into two things. Number one, that is the vitamin D. And what is the second thing? That is iron. But see here, the iron, though that is in the less amount, it is sufficient to meet the needs of the baby till the 6 months of the age. After the 6 month, mother feed is deficient in the iron. So, what advice we will give to the mother? We will ask him to start feeding, to give the feeding with the iron rich food. Okay, this was one of your question in your FOB calls. So please do remember mother feed that is deficient in the vitamin D and iron after the 6 months. Okay, whenever they talk to you about the exclusive mother feeding and the deficiency, you should think of deficiency of the two things. Number one is vitamin D and number two is iron, right? Okay, this question we have discussed. A 9-year-old boy on the ninth centile for the last 3 years. For the last 3 years, they are basically want to ask you about the growth velocity. For the last year, the child is on the ninth centile. What is expected for his height centile to be on his chart? Definitely, what it would be for the last 3 years, he is on the ninth centile. Definitely, we will not expect that his height is going to be decreased this time. We will not suspect that it is going to increase to between 9th and 25th centile or 9, 25 and 50th centile. We will expect it is going to increase along the ninth centile. Okay, like this is not a any other growth velocity. If it is static for the last 3 years, we will suspect it is going to be at the same centile this year too. Okay, this question, that is the primary site of the absorption of the in the colon, that is about the water. Folate we have discussed, folate is going to absorb where? P for wheat. Okay, so for iron, vitamin B, and for this folate, we have formula of the Phi, Pho, and wheat. Your two things, your colon, everywhere water is reabsorbed, and carbohydrate that is absorbed from all part of your small intestine. Clear? We will memorize Phi, Pho, and wheat for your supplementation. For the small intestinal different parts for the reabsorption. Carbohydrate is absorbed in all parts of your small intestine, and water is absorbed in all parts of your large intestine. Right? For that, you will see like a picture that they have given in your recipe for reabsorption of different constituent in different part of the intestine. Okay. The next question, that is the repetition of the previous one. Child on the early stat, you will give vitamin D supplementation. Acrodermatitis enteropathica due to zinc deficiency, and Beggens, that is vitamin B12 deficiency. Okay. This is again the repetition of the same question, vitamin D deficiency with 25 hydroxy vitamin D that was very low, and that was leading to increased level of PTH and declined phosphatase. Hyperparathyroidism, okay. Next, see here, by hyperparathyroid, calcium is increased, phosphorus is low, and declined phosphatase, all they are raised. Okay. The last one, normal urea and creatinine, so it is not a case of the CRF, normal calcium but decreased phosphorus. High, okay, this is also the same repetition. Why high alkaline phosphatase and PTH? That was due to mutation in the fibroblast growth factor 23. Okay, right. These were all questions about your nutrition. Okay, basically, we have done the clinical cases of this nutrition and GIT together. So these, okay, this was, we have done this case. That was about your diaphragmatic hernia, right? Okay. So from this class, you basically, what we need to see, we need to see that table which we have done in one of your clinical cases. What are the different clinical pictures of different micronutrient and macronutrient deficiency? And if we talk about the GIT tract, we need to know which part of the GIT they are responsible for reabsorption of different micro and macronutrients. Okay, for that, please concentrate on the clinical cases. Clinical cases, every line, that is very important for your MCQs, right? So with this, we are going to finish our class. Tomorrow we will inshallah do our test. The things which we have discussed so far, we will do in the test tomorrow. Any question you want to ask me? Thank you. Okay.